The current prevalence of heart failure in India is around 1% of our total population, and according to conservative estimates, it should be at least around 10 million. Coronary heart disease, hypertension, diabetes, and rheumatic heart disease are the most common causes. In the Inter-CHF, a global study, the one-year mortality in heart failure patients was highest in Africa, around 34%, and which was followed by India, 23%. Indian patients with heart failure are younger, present late with severe symptoms, often have little formal education, negligible health insurance, and are still being treated frequently with only digitalis and diuretics. Well, some of the challenges and the biggest unmet needs in this field are lack of public awareness, delay in the diagnosis and so late initiation of the treatment, lack of serious efforts to put patients on guideline-directed medical therapy at the earliest, inadequate facilities for hospitalization, negligible remote monitoring facilities after starting the treatment, and lack of a multidisciplinary team to guide and evaluate, because heart failure is a multi-organ disease. So we do need multidisciplinary teams. Well, patients with acute decompensated heart failure, whenever they come to us, are always admitted in our Batra Heart Centre, usually in the coronary care unit, for acute assessment and prompt management using the guideline-directed medical treatment, which is started at the earliest. And we make an attempt to start all the drugs, all the therapeutic agents within a few weeks of discharge, if not earlier. Therapy, therefore, has to be individualized in the treatment algorithm, and it's not like everything fits in one. One has to change sometimes the priority of the treatment. The other thing is that our experience with biomarkers for the diagnosis and prognosticating the patient with heart failure is very, very gratifying. We use it not only in the hospital practice, but also in the camps and the centers in the remote areas, which is set up by our Gauri Kaul Foundation. And it has been very, very useful. These point-of-care tests readily diagnose and differentiate heart failure from other causes of shortness of breath. The test also gives a reliable idea about how severe is the disease, and after starting the guideline-mediated treatment, it also helps us in follow-up and tells us which patients are doing well and which patients are not doing so well. And this we can do by remote monitoring also. Besides this, a periodic monitoring of the renal function is always required.